Anju Jaggi, and I'm a consultant physiotherapist based in London at the Royal National Orthopaedic Hospital. I've specialised in treating shoulder problems for the last 20 years, and what I hope to do over the next 20 to 30 minutes is give a general overview on how to manage the unstable shoulder. This is a particular problem that I'm very passionate about and is close to my heart. So when we coin the term instability, effectively this results in symptoms for the patient, which can be anything from a dislocation, a partial displacement of the shoulder or a subluxation, a feeling of insecurity, such as an apprehension, as well as pain. The causes of instability can be multifactorial, which I will go on to discuss. But essentially, we commonly categorise the etiology of unstable shoulder into two distinct groups, traumatic and atraumatic. So there are numerous classification systems out there, all of which provide a framework, but they're very much based on a biomechanical presentation, i.e. the degree of structural damage, the direction of instability, and the relative laxity. The Stanmore classification system started to incorporate the role of dynamic muscle control, proposing that muscles both contribute to stability but also can destabilize the glenohumeral joint. And this can also occur in the absence of any structural damage. However, previous classifications have failed to recognize the social and psychological factors that may help inform in decision making and management, particularly for the individual patient. So let's talk about traumatic instability. This by far is the most common type of instability and is triggered by a high forced injury or particular event to the shoulder which has resulted in a dislocation, and this is often documented through an X-ray. There is a bimodal distribution in terms of who it affects. It largely affects the young male who is involved in contact type sport, but there is also another peak in the female older group as a result of falls. Isolated anterior instability is traditionally believed to account for over 90% of its shoulder instability, with posterior being relatively rare. However, recent studies have highlighted an increased incidence of both posterior and combined shoulder instability, particularly in the young active population. In a study done by Len Funk's team, where they reviewed cases over a 3-year period, they found that almost 50% were anteriorly unstable, 10% posterior, but up to 50% had a combined direction of instability. So therefore, when you're seeing patients, particularly young, involved in contact type sports, it's important to assess for more than one direction of instability. The other things to consider when someone has dislocated their shoulder is the associated injuries that can occur. Neurological injury is not common. The prevalence of getting a nerve injury with a dislocation is around 10%. About 2/3 of these will be related to the axillary nerve, and then another 10 or 15% can be related to the brachial plexus or the ulnar nerve. Greater tuberosity fractures and rotator cuff tears are much more commonly associated in the older population group, and therefore it is important to ensure that integrity of the rotator cuff and any fractures are recognised as management may need to alter. So when it comes to decision making, it's not just about the structure and the direction of instability that is important to recognise. Age, level of play, whether the patient is recreational or professional, position that they may be playing in, and the type of sport that they do could all dictate the decision on whether we operate or not in some of these patients, but also for the type of operation we may seek to do. Also, whether they may be a first-time dislocator versus the recurrent instability type problem. It's important from a physical examination to assess any neurological deficit, to assess for hyperlaxity, but also assess for stiffness. Clearly, you need to assess the acromioclavicular joint and the biceps, as these can commonly also contribute to symptoms and need to be excluded. Test, as I've said, for directions of instability, but also look at this in more than one direction, particularly in the sports dislocation. The British Elbow Shoulder Society have produced some guidelines to help with a flowchart around decision making for these patients, and this can be accessible via the reference. Essentially, for those patients above the age of 25 to 30, these patients can often be managed conservatively, and for those in a higher age group, perhaps a MRI or an ultrasound scan can be useful to assess for cuff pathology. But imaging is regarded more important in the younger population, where then surgical decision making may need to be sought sooner. So there are various clinical tests that you can perform. Apprehension tests are still useful in terms of picking up symptoms and the direction. Hyperlaxity is also a factor when it comes to decision making, not just locally at the shoulder, but also more generalized laxity, particularly in the younger female. And this can help to pick up other comorbidities such as Ehlers-Danlos syndrome or joint hypermobility syndrome, as the management may need to differ. Assessing for hyperlaxity injuries, in particular inferior laxity, can be done using the sulcus or using the hyperabduction test described by Jaggi. A difference in hyperabduction of 20 degrees or between the sides demonstrates inferior hyperlaxity and could indicate a stretched inferior axillary pouch. So when it comes to imaging, what we're really looking for is the degree of soft tissue versus bony damage. The MRA is the imaging of choice. Significant bone loss, which can include anything of more than 10% of glenoid loss and humeral head damage and an engaging heel sacs. And when there is significant bone damage, then a surgical decision is then to consider whether it's worth doing a bone transfer. Commonly, the operation now is known as the Latige procedure, or whether just a soft tissue repair would be adequate enough. And also within the MRI, you're looking at the degree of capsular stretch as well as labral defect. There are essentially three types of operation that are done. The arthroscopic stabilization, this would be done for the non-contact player. There is minimal bone damage. They're perhaps a first-time dislocator, and it essentially is a reattachment of the capsulabral structures that have become detached. The Latige can be performed both open or arthroscopically. The latter is actually quite technically difficult and can have high complication rates in the wrong hands. So it's best suited for the open Latige is best suited for the collision athlete with bone loss. And this generally tends to involve taking the coracoid and using it as a bone transfer to the front of the socket. They also take the conjoint tendon and then may, in addition, do a capsular shift. This is often known as the triple block effect. So you've ended up with a really stable anterior construct to the shoulder. The adolescent athlete is by far probably the most challenging, particularly if they end up with recurrent instability. And this young group tend to fail both non-operative treatment as well as operative fixation. So the challenge with this group really is because they are particularly hyperlax, and there's a genetic predisposition perhaps to them suffering instability. So for some, there may need to be some subtle counselling around their career prospects if they're thinking about professional sports. But if you do end up needing to offer this group an operation, then perhaps an open band heart repair with a shift to address the hyperlaxity is probably the first thing to consider, so that then if this does fail, there are other options for revision. So what about rehab? Is that an option for patients who've suffered a traumatic dislocation? So the evidence for non-surgical intervention is extremely limited. There was a Cochrane review just published last year, and the studies predominantly looked at position of immobilization, so external rotation versus internal rotation. There were no trials actually comparing active rehabilitation or physiotherapy in terms of effectiveness for first-time dislocations of the shoulder. Currently, there is a UK trial going on. This is known as the Artisan, where they are looking at one session of advice versus a course of physiotherapy for the first-time dislocator, but we're still awaiting the trial results. What has been an interesting trial is one that is come out from Denmark, where they used something called a Synex program versus a standard home exercise program. The Synex program basically was a 12-week program of 7 exercises going from basic to elite versus a home exercise of 5 exercises done 3 times a week for 12 weeks. They used the Western Ontario shoulder instability score to rate improvement at about 12 weeks following the program. What they found was that WOSI scores were slightly better with the Synex group, and actually it wasn't statistically significant, but the Synex group tended to be less likely to go on to surgery. This program can be accessed via the article, but what it was including was a neuromuscular type form of exercise where the kinetic chain was incorporated, where there were ballistic movements, as well as weight-bearing exercises, rather than just 5 simple standard rotator cuff strengthening exercises. So post-surgery, there's a large variation, but in the last 10 years or so, there's been a real shift towards accelerated rehab programs. Usually for an arthroscopic shoulder stabilization, the patient's rested in a sling for about 3 weeks. They may be allowed to start some gentle movements below shoulder height, and then a progressive strength training program, usually from about 4 to 6 weeks onwards. If they're not professional athletes, the sort of recreational soccer player, rugby player, then these patients will probably return to sport at about 6 months. But in the more professional athlete, where they're supervised physio, they can start immediate active movements and some strength exercises within safe zones, avoiding combined movements such as a position of abduction and external rotation. And for some of these athletes, they could return to play at about 4 months. So there are various physical parameters that physiotherapists and surgeons are using to help with deciding when patients are ready to return. The SARTS test is a battery set of tests that's been validated by Margie Olds out in New Zealand. These are a combination of both closed chain as well as open chain tasks, and gives a scoring system to allow you to decide whether the patient is ready to return to sport. Increasingly, following the ACL research, there also seems to be a need to look at the psychological readiness for patients to return to play. And so scores are now being validated for this group too, such as the shoulder instability return to sport after injury, where they're showing whether there is validity and reproducibility to try and quantify the psychological readiness for patients to get back to their level of sport. So now we come on to discuss atraumatic instability. By far, this is a far less common group. Prevalence is regarded anything from sort of 4 to 10%, although I suspect this is higher and probably could be more in the region of 20 to 30%. These patients are categorised as those who are starting to develop symptoms of instability, but with no history of trauma. There's no documented evidence generally of a full dislocation. They can present with pain, apprehension, subluxation. There can be associated capsulolabral dysfunction. There is generally hyperlaxity. They don't have a bony problem, and they have positive apprehension tests. There is a further challenge of classifying this group, as there are so many terms that have been widely used, anything from atraumatic, muscle patterning, multidirectional, voluntary, bidirectional. So this does make it difficult to understand what is the best management and what are the groups that we're really talking about. Like I've mentioned, these can be patients who could be the overhead athlete, people who acquire subtle capsulolabral lesions as a result of overuse injuries, may even be the group that present with internal impingement type symptoms. And then there are the patients who also sit with generalized hyperlaxity within the hypermobility spectrum disorder, such as Ehlers-Danlos syndrome, and then may come with associated psychosocial morbidities such as depression and anxiety and functional movement disorders. So the basis for prescribing exercises became the mainstay of treatment for atraumatic shoulder instability, and this was based from the Birkhead and Rockwood paper in the JBJS back in the early 90s. They attempted an exercise program with both traumatic and atraumatic shoulder instability. Only about 16% of the traumatic group responded with a good to excellent result with exercise, compared to up to 80% of the atraumatic. So therefore it was felt that exercise rehab was a good course of management for people who did have atraumatic instability. The principles of this is essentially to try and improve the balance of strength around the shoulder girdle, which would involve obviously focusing on the cuff, the deltoid, the scapular stabilizers. More recently, people have put a particular emphasis on the importance of upward rotation of the scapula, particularly in those patients that have an inferior component to their instability, and then also incorporating the kinetic chain. Warby's group did a systematic review, found about 7 studies, but there was a very high risk of bias and a real study heterogeneity to make any strong conclusions about what type of exercise was best for this group of patients. So they actually went on to do a randomized clinical trial comparing the Rockwood program versus their program for multidirectional instability. The Watson program essentially involves patients keeping the position of the scapula elevated and then doing a progressive loading program on the cuff and the deltoid. This involved 12 weekly physio sessions, and the patients were evaluated at around 6, 12 and 24 weeks follow-up. The trial showed that there seemed to be a significant favouring towards the Watson program, but the assessors and participants weren't blinded. The assessors and participants were blinded, but not the therapist, and the study was underpowered. And what they also found was the participants tended to be less compliant in the Watson group compared to the Rockwood program. Another program that's started to be utilised and is widely accessible, you can download the program from YouTube, is the Derby Shoulder Instability program. These exercises are focused to improve strength, stamina, speed of muscle activation, plyometrics, proprioception. The idea is you take 2 exercises, one from each group, and they are set targets that you have to achieve to progress through, so that the patient incorporates more higher reps and improved stamina. And the idea is you demedicalize the problem for the patient and encourage sort of long-term management. The Derby group published updated results. About 66 patients, 15 were lost to follow-up. They averaged about 6 sessions over 30 weeks, and they showed significant improvement in pain, stability and function, but the follow-up for these patients were only at the point of completion of therapy. Our own experience at Stanmore is that we tend to see a particular group that seem to be resistant to treatment, predominantly females. They have associated Ehlers-Danlos syndrome and hypermobility, and a high prevalence of almost up to 30% of psychological comorbidities. They also tend to be unstable, predominantly in a posterior direction, and with a related downward rotation of the scapula. They have poor grip strength, which correlates with poor cuff strength, as well as globally being quite weak. And they really do need a very progressive scapular loading cuff, but also kinetic chain type exercises, and on average need about 10 sessions over a 6-month period. So seem to take a lot longer to make the strength gains because of the degree of their weakness globally. So when it comes to surgery in the atraumatic group, this can include people with microtrauma, for example, labral tears and biceps irritation. And the debate really is whether these are secondary to lack of good dynamic control or actually contribute to the symptoms. So a 3-armed randomized trial was actually undertaken a few years ago and has been published in the BJSM, where they took type 2 SLAP lesions seen on MRA scan and randomized the patients into 3 groups, one receiving just an arthroscopic procedure, the second doing the arthroscope and going on to do a labral repair, and the third having a biceps tenodesis. And what they found was there was no significant benefit over just a sham procedure. Although I think there is probably some argument to possibly offer patients in the younger age group in the overhead athlete, where perhaps conservative treatment has failed, as offering them this operation as a possible option. But I think the way forwards is really surgery plays little role in this type of instability. The British Elbow Shoulder Society have also published some guidelines on how to manage patients with atraumatic instability, and our experience at a specialist unit alongside others in the UK have come up with a sort of list of patients that, if you recognise these symptoms earlier, may do better in more MDT specialist units, particularly those patients who are attending A&E frequently. The joints seem to be persistently displaced, there's high levels of pain, there's associated stress, absence from school and work, and these patients probably have a central component to their presentation and therefore may be better managed by a team rather than just a program of exercise. A component that's really becoming interesting is the growing area of functional MRI, and even in the unstable shoulder, brain changes have been observed in emotional centres linked with fear and anxiety, pre and post traumatic dislocation. This becomes interesting in the sense of that when we're probably operating on patients, is it the biomechanical effect of providing stability, or are we influencing more the perception that they perceive now their shoulder is more stable and therefore they have less anxiety to start to return back to the level of function? And it's interesting to note that a very recent paper by Olds has indicated that kinesiophobia still remains an issue for the first time dislocator even 12 months post the event. So when it comes to addressing rehab, graded exposure, perhaps the use of virtual reality now, might benefit our patients to reduce the fear and anxiety towards using the arm and not worrying about it becoming unstable. And just to finish off was that the team from Liverpool have also started to look at functional MRI in the sort of atraumatic group, the type 2 and type 3s, and shown that these patients sort of appear to be working much harder at a cortical level, almost to try and maintain stability at their shoulder. So, in conclusion, to finish off with, when we're thinking about the unstable shoulder, it's important to manage the individual. So it's not just about structure and direction of instability, but the level of sport, their age, their strength, the position they may be playing, how motivated they are, the associated laxity they may have, the fear of wanting to move. And all of this needs to be taken into account with shared decision making between the patient, the surgeon, and the therapist. Thank you very much for listening.